Good morning and welcome to Obstetrics and Gynecology Forum. I am your host, Dr. Olabola Olaniyi. Today we shall be continuing our discussion on antepartum hemorrhage, which we have established is bleeding in late pregnancy. And we have established also that antepartum hemorrhage is responsible, among other causes of obstetric hemorrhage, as a major and the leading cause of death in pregnant women. Today, we are going to be discussing another important cause of bleeding in late pregnancy, which we refer to as placenta previa. So we are going to be discussing it under the following outline. Now, going by the way of introduction, what is placenta previa? Placenta, as we know, is that structure within the uterus that maintains contact between the baby inside the womb and the mother, supplying oxygen, nutrients, and everything that the baby needs within the womb. Now, what is previa? Previa means something that is coming before another one, that is something coming before. Now, placenta previa thereby means that the placenta is coming, is presenting before the baby, is coming before the baby. So now, what happens in placenta previa? What happens is that the part of the uterus where what we refer to as the cervix, where the baby comes out during delivery, the placenta is located in that part of the uterus. So it can be located completely in that lower part of the uterus, or part of the placenta may be located in that part of the uterus. And placenta previa, like we said, in conjunction with abruptio placenta that we discussed in our last session, are the major causes of bleeding in late pregnancy. And this condition can occur in 1 out of 200 deliveries. It can occur 1 out of 200 deliveries can be complicated with this condition. And out of those 1 in 200 deliveries, about 90% of them, that means 9 out of 10 of such cases will occur in women that have had deliveries before. That means it's not very common in first pregnancies. So placenta previa is commoner in women that have had previous deliveries. So, and because of the importance, we know that this condition may lead to death, it may lead to serious disabilities, and it may lead to serious complications in the child. So now, what are the causes of placenta previa? Like in other causes of bleeding in pregnancy, we may not be able to pinpoint any particular cause, but there are things that we refer to as predisposing factors. There are factors that, if they occur in a pregnant woman, may make them have a higher likelihood of having this condition. So some of those conditions are conditions that will affect what we refer to as the endometrial lining. The endometrial lining is that lining of the inside of the womb where the pregnancy attach can where pregnancies attach and grow. So that lining of the any condition that affects that lining of the uterus will make a woman to be predisposed to placenta previa. So what are those conditions? It has been found that placenta previa, like I said, is a disease of women that have been pregnant before, to the extent that a woman that's had 5 or more pregnancies will have times 10 the rate of this condition in an average population. What I mean is that we said that 1 out of 200 women, or one out of 200 deliveries may be complicated with this condition. But in a woman having a fifth or more pregnancies, the prevalence or the incidence may approach 1 in 20. That means 1 in 20 of such women may have this condition. So it's a disease of women that have been having babies before, and it's a disease of older women. It's commoner in older women. So what are the other conditions that can predispose to this condition? Conditions that has caused any scar or injury within the womb or within the endometrium will also predispose a woman to this condition. Such conditions include women that have had cesarean section to deliver babies, women that have had surgery for removal of fibroid, which we refer to as mammectomy. Women that have had, even women that have fibroid, even without surgery, because of the location of the fibroid within the uterus, can make the woman to predisposed to having low-lying placenta. And other conditions like termination of pregnancies, like what we commonly refer to as dilatation and curettage, that's D and C, because during the procedure injury may occur to the lining of the womb. Such conditions may lead to, may predispose a woman to having this condition. Another important condition is what we refer to as manual removal of placenta. Some women have difficulty expelling the placenta after delivery of the baby, and such cases your doctor may take you to the theatre to go into the uterus, put their hands into the uterus to bring down the placenta. Such conditions too may predispose the woman in subsequent pregnancy to have placenta previa. Now, aside conditions that cause scars in the uterus, any condition that will make the size of the placenta to increase will also predispose to this condition, because the larger the placenta, the larger the likelihood of the fact that the placenta may encroach on this part of the uterus. For example, in cases like twin pregnancy, when a woman has twin pregnancies, the size of the placenta may be larger than normal, and in such cases the likelihood of the placenta coming to that part of the uterus is higher. So there are other conditions like women with anemia, women with hydrangeas. Some of those conditions also can predispose. And there are some conditions, we call them the abnormalities of the placenta. What we call sustentoriate lobe of the placenta. Some placenta may have, aside the regular bulk of the placenta, they may have another smaller placenta that may eventually come to the lower segment. And what we call placenta, there is a very large surface of placenta in a condition where placenta is virtually covering all the surface of the uterus. Such people too will be predisposed to this condition. Another important point that we must have in mind is smoking. Smoking is a predisposing factor for placenta being in the lower uterine segment, because in women that smoke, the oxygen concentration within the uterus is reduced because of the effect of certain chemicals within the cigarette. We call it nicotine, which will predispose to carbon monoxide accumulation in the womb, reducing the oxygen supply. So in such women too, they will be predisposed to having their placenta in the lower part of the uterus. Now, how do we classify this condition? There are different attempts at classifying this condition, but for the purpose of this discussion, we are going to give a very simplified classification, which will make it easier for our viewers to understand. This is what we call marginal placenta. That means the placenta is getting to the margin of the, this line is the margin of the cervix, which we refer to as the gateway to the uterus. When the placenta is getting to this margin, but it's not covering the entrance into the uterus, we refer to it as marginal. It can be marginal, it can be lateral. Lateral means that the placenta is located within that lower part, but it's not getting to the edge of the cervix. So if it's that, we can refer to that one as type 1, or what we call lateral placenta. When it gets to this margin, we will refer to it as type 2, or what we call marginal placenta. It's just at the margin of the cervix. Now, if the placenta has gotten beyond the margin and is covering the hus, you see this in this pictorial representation, that means the cervix has been open. You can see that the placenta is getting across that opening. We call this one partial placenta. It's covering that part partially. Now, when it's covering totally, it's covering the whole of that entrance into the uterus. It's totally covering it. Whether the uterus, the cervix is opened or closed, we refer to that one as complete placenta previa. So it can be marginal, it can be partial, it can be complete, and like I said, it can be lateral. Now, and when you look at it, it can also occur anterior, because that part of the uterus is, when you look at it from what we call the cross section, as if you are cutting it from up, there are like 4 parts. It can be anterior, it can be posterior, it can be lateral. So when you look at it, whether it's anterior, posterior, or lateral, what is important is the degree of the covering and the location. For example, if the posterior placenta previa has a clinical significance, because when the placenta is located posteriorly, despite the fact that it's not covering the host completely or even partially, it may affect labor, it may affect the baby coming down through the back canal during labor, because that posterior part is where the head of the baby, there is like a space in the posterior part of the woman's back canal where the head usually goes in. When it's located posteriorly, it may prevent the head of the baby to go into the back canal. Now, that said about the classification. Then the diagnosis. How do we make the diagnosis? Like, in all my discussions, I like talking about predisposing factors. Now, it's very important because for any clinical condition, any medical condition, if you are able to predict such people that will be predisposed to it, we can prevent it from happening, or we can prevent complications in such women. Now, we have said that women that have had surgeries of the uterus, women that have had the dilatation and curettage, women that are anemic, and so on and so forth. Such women, or women that have had several previous deliveries in the past, are at risk of this condition. So if you are at risk, you must know at the back of your mind that this my pregnancy carries a higher risk than certain other pregnancy, and that is why we normally say that for every pregnancy you must go and see a professional, because in the earlier stages of pregnancy, pregnancies are usually classified based on risk. If your pregnancy is low risk, good. If your pregnancy is high risk, certain things may be done to be able to prevent complications. Now, when you have all those risks, please make sure when you are pregnant you go for an ultrasound and go to facilities where you can be well classified. Now, how do these women present? Usually in some women, they may have what we refer to as warning hemorrhages in the earlier part of pregnancy. We refer to it as warning hemorrhages. Women in pregnancy may start seeing what we refer to as spotting, and that is why when some women come and say, I've been pregnant and I'm still menstruating, we try to convince them that sometimes what you are referring to as menses is not menses. You are spotting, you are seeing blood. So some women have what we refer to as warning hemorrhages. They just see spots of blood, bright red blood, that will not give pain, that will not give anything, and the spotting will stop without any intervention. That is what we refer to as warning hemorrhages. When you notice such condition in pregnancy, please present to your hospital. Now, usually the significant bleeding, what we refer to as major hemorrhage or bleeding in pregnancy, usually occurs in the later part of pregnancy, from around, let's say around 12 weeks to like 4 weeks before your due date. That is the later part of pregnancy. So the what we call major bleedings usually occur around that time. That is the time where the baby is getting closer to maturity. Now, what happens is that a woman may have sudden profuse bleeding in that later part of pregnancy, bright red blood just coming out from you. It's usually much, it's significant, and there may not be any pain. There may not be signs of pain, or like abdominal pain or labor pains, except in about 10%, that's 1 out of 10 cases, where a woman may notice some pains. And in such cases, that means aside the fact that the woman is bleeding from a low-lying placenta, that means placenta may also be separating, or maybe labor is about to start. So usually what we refer to as painless previous bleeding may occur in the later part of pregnancy. That is how the woman will usually present. Now, there are other things that may give us, that may be a pointer to the fact that the placenta may be lying in the lower part of the uterus, which you may not know as a woman, that your obstetrician or your doctor will be able to pick. Such women, when they get to the hospital, the bleeding don't normally affect, in most cases may not have affected their status. Their BP may still be normal, their pulse rate, everything may still be normal. On examination of the baby in most cases will still be alive. So in most cases the baby will still be alive, and when your doctor checks your baby, your womb, there won't be any sign of labor. In most cases there won't be any sign of pain. Your baby can be easily assessed, palpated, because there is no contraction, no tenderness, no pain. Now, One of the important things that your doctor may be able to pick is that in such cases the incidence of baby lying abnormally is higher. What we mean baby lying abnormally is that we know that usually the baby lie with the head in the lower part of the womb, because the baby usually come comes out with the head. So in such cases the baby may be lying like this, may be lying oblique, maybe line will be coming with the maybe coming with the limbs or the legs. So in such cases, when your doctor picks what we refer to as abnormal lie and abnormal presentation, it may be a pointer to the fact that something is occupying this lower part and is preventing the baby from coming into that part of the womb. Now, the other thing that may occur is that during the later part of pregnancy, the head of the baby usually comes into this part, what we refer to as engagement, and what our mothers refer to as lighting, that you have a feeling as if the size of the uterus has reduced because the head is coming down. In women that have that the placenta is in the lower part of the uterus, such will not be able to occur because the head will not be able to go into that part, because something else, which is the placenta, is occupying that part of the womb. So features of abnormal lie: high presenting part, that is the baby being in the upper part of the uterus, and all these ones may be a pointer to the fact that something is occupying that part, which may be the placenta. So, and from the history, from your history too, your doctor will know that okay, this woman has had surgery before, has had mammectomy, has had termination of pregnancies. Such issue also will give a signal to your doctor that you are at risk of such conditions. So what do we do now? The talking about the treatment of this condition, the diagnosis too. Now we have said it in our previous discussions that when a woman is bleeding in late pregnancy, you should not be examined through the vagina or through your anus, because if you are not sure whether the placenta is low lying, and any attempt to insert fingers into this part of your uterus will cause further bleeding. So until we are sure the placenta is not low lying, no examination must be done through your vagina. Now, what usually causes the bleeding? Bleeding usually occurs because toward the end of pregnancy, this part of the womb is getting prepared for labor. It may be opening up gradually. When that part is opening up, what we call effacement may separate the placenta and it will cause bleeding. Any trauma can cause bleeding. Anything that touches this part of your womb, like sexual intercourse. During sexual intercourse, if there's trauma, it can also cause bleeding. And that is why when this is diagnosed in the later part of pregnancy that your placenta is low lying, your doctor will tell you to avoid sexual intercourse in order not to provoke bleeding. The other thing that can provoke bleeding is what we call infection or inflammation of the placenta. If infection gets to this part and irritates this part, it can further cause bleeding. And sometimes separation can also occur in the placenta that is abnormally located, like we have discussed in abruptio placenta. So if there is anything that causes separation, bleeding will occur. And when we are talking of confirmation of this diagnosis, ultrasound is very important. With the advent of ultrasound, it can be diagnosed clearly in up to out of 100 up to 95 to 97 cases will be diagnosed with ultrasound. Now, in order to make the diagnosis more accurate, there are advanced ultrasound tests that can also be done, like what we call the Doppler studies, that can make this to be easily diagnosed, or what we call a transvaginal or translabial ultrasound, where the ultrasound will be done through the vagina in an experienced hand, because that is like we have said, anything that can touch this place can provoke bleeding. So such transvaginal ultrasound will be done by an experienced sonologist, not to provoke bleeding. So with that, the diagnosis of placenta previa can be made and be managed accordingly. Now, there are other ways of diagnosing low-lying placenta, like what we refer to as magnetic resonance imaging, like what we call X-ray, placentography, radiological scanning, and But some of these conditions are not as accurate as ultrasound, and they are not really available. So ultrasound will suffice in the diagnosis of this condition. Now, the management of this condition will depend on some other factors: the maturity of the baby, the age at which the bleeding is occurring, or the age at which this diagnosis is made, the state of this service or the state of labor, and the general condition of the mother and the degree of bleeding. So most of these factors will determine how we are going to manage this condition. So, but like I said, when you notice bleeding, please go to your hospital. And let me point out here that this is not a case that is managed in peripheral hospitals, in health centers. A case of bleeding in advanced pregnancy is a case for tertiary hospitals, where facilities are available for blood transfusion and immediate surgery. Now, when you get to the hospital, management can now be divided into either expectant or delivery. Like I said, any condition of bleeding, the first thing is to stabilize and cross-match blood. Depending on the degree of bleeding, at least 2 units of blood is cross-matched. Now, expectant management is carried out when a woman has bled in late pregnancy, but the baby is not matured, the lungs of the baby is not matured. So what we do in such a case is to try to gain some days for the baby to mature. If the bleeding is not too profuse and it's not life threatening, the woman is stabilized, may be transfused, get additional blood ready in case of further bleeding, and the pregnancy is monitored on the bed, where facilities are that in case of further bleeding or complication, immediate cesarean section can be carried out. And in such cases, some drugs may be given to the woman to stop the uterus from contracting, and some drugs may be given to the woman to make sure the baby matures faster. So that one is what we refer to as expectant management. And when the baby is time, like 4 weeks to delivery, when the baby is matured enough or is tested to be matured enough, then the baby can be delivered. Now, for women that will need immediate deliveries, when the condition of the woman or the baby is compromised, immediate deliveries will be required, usually through cesarean section. Now, when bleeding occurs when the baby is matured, there is no use waiting, you can deliver the baby. Now, and for that delivery, usually the best is cesarean section, because of the other risks involved. When there's blood and there are facilities, cesarean section is the fastest and the best way of delivering such women, although some can also be delivered through the vagina. Now, the importance of cesarean section is that it must be done by a very experienced obstetrician because of the complications that may occur during the surgery. One of the complications may be uncontrolled bleeding. One of the complications may be bleeding from because sometimes the surgeon will need to cut through the placenta and it may cause bleeding from the baby. So if the surgeon is not fast enough, the baby can also be affected. So, and sometimes because of this part of the uterus that is very thin, placenta will have gone into the substance of the uterus, and after delivering the placenta, bleeding may be uncontrolled. There are certain procedures that can be done to stop the bleeding, and in some cases, in fact, it's where the uterus has to be removed to control bleeding. So this is not a surgery that can be done by just any surgeon. So it's usually done by experienced obstetricians. Now, for the vaginal bleeding, for vaginal delivery, for women that have marginal placenta that is not actively bleeding, or the bleeding is not profuse, and the woman is stable, the baby is stable, and the labor is going on well, such women under close monitoring can be allowed to have vaginal delivery because the placenta is not interfering with the descent of the baby. But such deliveries are also monitored in a good center where there are facilities for what we call electronic monitoring. And in such cases, if there are signs of complication or compromise, immediate cesarean section is carried out. Now, what about the complications of this condition? We have said that bleeding in the mother can lead to shock, can lead to death. We have said that even this can lead to the loss of the uterus in some cases. And even in pregnancy, the current bleeding in pregnancy, when a woman is bleeding what we call warning hemorrhages can affect the growth of the baby. So the baby may not grow well, the baby may lead to death of the baby or the mother. And because of the abnormal life, the risk of surgery is higher, and the complications of surgery and blood transfusions are also are very high. And we normally say that antepartum hemorrhage begets postpartum hemorrhage. That means a woman that bleeds in pregnancy has a higher likelihood of bleeding after delivery. So they are at risk of having what we refer to as postpartum hemorrhage, which can also lead to death and other serious complications. And in the baby, sometimes baby may have to be delivered prematurely with risk of problem from prematurity, permanent disabilities, or even death. So those are the likely complications. And what about the outcome? Like I said, with the improvement in surgical techniques, availability of blood facilities, and better immediate and urgent diagnosis and treatment of these conditions, the rate of death from this condition is now very low. Less than 1 out of 100 of these women can lose their life because of this condition, unlike before. So the rate of death is now very low when they are well managed. And for the baby too, the outcome is better. Although as high as 1 out of 10 babies may still die or suffer serious complications from this condition, but the baseline is conditions that are diagnosed earlier and good management is instituted, we have better outlook. So what we are saying is, don't please procrastinate, don't hesitate to go to the hospitals when you notice any of these complications, and not just any hospital, go to a tertiary level of care where you can get the best. So in conclusion, we have been able to identify the importance of this condition. We have been able to elucidate the likely predisposing factors, which we can also notice as pregnant women and seek help. And we have told us that this condition is manageable. So, and whatever we can do to prevent this condition is very important. Like I've been saying, prevention of criminal abortions, surgeries, if they have to be done, must be done in a good facilities where precautions can be taken for further delivery. And especially a woman that has surgery, cesarean section, mammectomy, are not women that can deliver in any facility. Once you have had surgery before, please, for your subsequent deliveries, go to a facility where there are specialists who can adequately manage your condition. With all these things said, and with all these precautions borne in mind, I believe that the pregnancies of our women can be made safe. uh, Thank you for listening. You can watch. If you have any question or comments, don't hesitate to get back to us. We are going to attend to your questions. Thank you very much. God bless.